I should say something, so
Hi, welcome.
We are live.
Thank you. And welcome to all, both commissioners who are here in person at the HPC offices and on Zoom, and the public via the YouTube live stream. We're trying today for the first time a hybrid meeting, so we'll look forward to feedback on how that works. We have several important topics to cover today. First, we're going to discuss information and testimony from the 2024 Healthcare Cost Growth Benchmark hearing that was held last month on March 15th at the Massachusetts State House. We'll then vote to establish the Healthcare Cost Growth Benchmark for 2024. Then we're going to hear from the Office of Patient Protection regarding health insurance consumer protection, and there'll be a vote on a recommended final regulation. Then we'll have HPC staff share an update on the evaluation of the Sustainable Healthcare Innovations Transformation Program. And then I will ask the commissioner to discuss the recent workforce report and reflect on the special event that we held, including next steps for policy solutions and the HPC's role. And then to close out the meeting, as always, we'll have agency updates from our executive director and his report. So our first order of business is to vote with them, dispense with the minutes from our last board meeting, which was on January 25th. And I'll ask Colleen if you can manage our vote.
I will do. Do I have a motion on the minutes?
motion.
And a second?
Second.
Okay, great. We'll start again with a roll call vote because we are in a hybrid setting. And I'll start with you, Madam Chair.
Aye.
Vice Chair Cohen,
Aye.
Commissioner Berwick,
Aye.
Commissioner Blakeney,
Aye.
Commissioner Castiel,
Aye.
Commissioner Cutler,
Aye.
Commissioner Foley,
Aye.
Commissioner Haupt,
Aye.
Commissioner Master Giovanni,
Aye.
Commissioner Kwasnick.
Abstain. So I
Thank
wasn't
you.
here for last meeting.
Absolutely. And Acting Under Secretary Sung.
Aye.
Thank you.
Great, thanks so much. So our first topic today is an important one. It's our discussion and vote on setting the 2024 healthcare cost growth benchmark. We're going to ask our executive director to present on both what the healthcare cost growth benchmark is and the decision ahead of us, and also to summarize the feedback that we got at the recent hearing. And then we will move to discussion by the commissioners and a vote. So with that, let me turn it over to Executive Director South.
Great. Thank you, Madam Chair. Good afternoon, commissioners and members of the public for this meeting of the HPC board. As Chair DeVoe said, our first important business for today is setting the benchmark for the calendar year 2024. First, I want to orient commissioners and the public to this process, the role of the benchmark, summarize the testimony, and then turn it back to you, Madam Chair, to lead a discussion among the board. So on this slide, you can see the annual process. It begins in January each year with the setting of the potential gross state product estimate. This is an important economic metric that is tied to the benchmark. A month ago, on March 15th, we held a public hearing with the Joint Committee on Healthcare Financing to receive testimony on the consideration of the potential modification of the benchmark. And we are here today on April 12th to vote to establish the benchmark. The statutory deadline in the law is April 15th, so we are a few days ahead of that. There are some remaining steps in this process. If the board does elect to vote to modify the benchmark, which would require notice to the Joint Committee and potential legislative review. On the next slide, you can see here our statutory obligations when it comes to setting the benchmark. The law was very clear in setting forth 3 different time periods that provided flexibility and authority for the board to set the benchmark. We are now in that 3rd period, indicated in the orange box at the bottom of the slide. By law, the benchmark is set at the statutory rate of potential gross state product, which I just mentioned was set at 3.6% at the beginning of the year. However, the HPC board can vote to modify the benchmark to any number, both higher or lower than 3.6%. A vote to modify would require a 2/3 vote of the board. A vote to stay at the statutory mandated rates of 3.6 requires just a majority vote of the board. On the next few slides, I wanted to return to the hearing that we held a month ago. At that hearing, in addition to receiving public testimony, we also had presentations from the Center for Health Information Analysis on their annual report and the Health Policy Commission. On this slide, I've summarized some of the key data findings that were presented at that hearing. CHIA presented their latest annual report, which examined spending from 2019 to 2021, which showed an annualized increase rate of 3.2%. We also identified some particular sectors within the healthcare spending that were driving growth. In particular, we noted that there was a 7.7% annualized growth in prescription drugs, and 5.4% annualized growth in hospital outpatient spending over a 2-year period. We continue to note the affordability challenges, especially for prescription drugs, with increasing pricing, driving up the average branded prescription to over $1,000. These affordability challenges are also highlighted on the right-hand side of the slide, where we see increased rates of uptake in high deductible health plans, increased out-of-pocket costs for common prescription drugs, and that the average annual family premium in Massachusetts is now almost $25,000 a year. At the hearing, we also received a number of data and analysis on hospital finances and some of the hospital and labor expenses. We have some updated data that we wanted to present to the board and to the public today on some of those topics, because we have hot off the presses some more recent information to share. I do want to note, before I turn it over to David Auerbach to present some of this new hospital finance information, that while hospitals are absolutely an important part of the broader measurement of total healthcare expenditures, they still only represent 40% of THCE, or 40% of the entire benchmark spending. So an important part, but still less than the majority of total spending. But I'll turn it over to David Auerbach now to walk through some of these new slides.
Thank you, David. And that's right. And I'll also just add that 40% is about evenly divided between hospital inpatient spending and hospital outpatient spending. And they're both included here, but there's a particular focus on the inpatient side in some of the discussions recently and some of this material. Okay. So to start off with, here's the latest data from CHIA. And what this data is showing is total hospital margins as of the very final calendar quarter of each year. And so what's new and important is that last data point you see there, that is reflecting the period from October 1st, 2022 to December 31st, 2022. And then each of the data points before that shows that same fourth quarter only in the previous years. And so, noteworthy, the statewide median total margin is that orange, and that was about 4% in that last quarter when it's depicted this way. And so these margins are positive in each of those years. So that's the first thing to note, is those margins are positive in the most recent quarter. Now the CHIA report, okay, let's go to the next slide, please, that we showed at the benchmark hearing only had data through June of 2022. And that was where we saw that downturn. And so what we've done here is we've taken the most recent quarterly data I just showed and compiled quarterly data going back to 2017. So you can see the full quarter by quarter trend. And what we're showing is that total aggregate margin, which is the profit margin. In that fourth quarter, that represents about 500 million in total profits, so revenue minus expenses. And so you see here that trend of positive margins throughout, with the exception of that first quarter of 2020 when the shutdown began, and then those first 2 quarters in 2022. And unfortunately, we don't have data for Q3 of 2022. So important to note is these are the total margin combining all hospitals together. In that, even in the fourth quarter of 2022, 14 hospitals had negative margins, while 33 had positive margins. And of those 33, 13 of them had margins over 10%. So there's, of course, a distribution of experiences at the different hospitals. Okay, next slide, please. And we have a little more detail on the different components of those margins. The margin includes both operating revenue, which is your patient care revenue and other sources like cafeteria revenue, non-operating revenue, which is reflecting asset sales and investments in the stock market, and then expenses and the different components of those expenses. So first note, the total revenue is the purple line, and you see that increase in the very last quarters there, from Q2 of 22 to Q4 of 22. That purple line goes up quite a bit. And the positive margin comes from the fact that that purple line jumped up above the total expense line, which is in the yellow. So total revenue, purple, total expenses, orange or yellow, and the revenue being higher means the margins were positive. And that increase in revenue was pretty much an even contribution of a growth in operating revenue in the blue. You see that line going up, and the non-operating revenue in the green on the bottom of the chart, that also increased. And it's noteworthy that that non-operating revenue was below zero in that Q1 of 22 and in Q2 of 22. And that is coming from the fact that the stock market was down in those quarters, and that contributed to the negative margins we saw in the beginning of 2022, as well as factors such as the Omicron wave, which really led to a big increase in labor expenses and longer length of stay, for example. And so let's go to the next slide and we'll see a little more detail on that as well. Although we don't have data coming, as recent as early 23, what we did here was we used a third-party data source that we have used before that correlates quite highly with GIA's data as well, to get some insight into even the last few months up to the end of February of 2023. And we're tracking some of those key hospital metrics that contribute to the financial performance that we saw, such as labor expenses per discharge. And what this chart is showing is each data point here is showing you the change in that value from the year prior. And so if you look at the dark blue, which is labor expenses per adjusted discharge, it turns negative in December 22, January 23, February 23. That negative means those labor expenses per discharge are below what they were a year earlier when you had the Omicron wave. So those labor expenses have dropped since that peak in early 22, which really contributed to the negative financial performance. And length of stay in the yellow is also down. It's also negative, which means length of stay has gone down from where it was in early 22. And that also, the length of stay also hurts the financial performance, because you're expending resources on those patients, but not getting additional revenue because they're just in the hospital longer. So that has also improved. And at the same time, discharges are positive. So those increased since the Omicron wave. Patients staying less long in the hospital allows you to have more discharges, and the revenue increases. So those are some of the key trends, bringing you up to even some of the most recent months, which is an important update since the data that we showed just a month ago. Okay.
Great. Thank you, David. Before I get into the summary of the testimony received, just want to pause to see if there are any questions from commissioners on the data that David Auerbach just presented.
David, excellent job with that. I really like the data, the detail. I was just wondering, when we looked at the margins, were you able to break down the margins by whether it's a community hospital or one of the larger academic type facilities? Do we have that broken down? Because that may help us when we work with folks at the state in terms of maybe helping some of the community hospitals, having different numbers for them. Do we have that, David?
That's a good question. I mean, actually, if you can go back to the first slide from Chia, they do that breakdown. And you can see it's a little hard to see, but I'll point them out to you. The academic medical centers are the dark blue, which you see there in the last quarter being positive, and they were negative in that last quarter of 21. The community high public payer hospitals are the light blue on the top there. Community hospitals are in the green and the teaching hospitals are in the gray. So there's some differentiation there. And again, note that these are medians within that cohort. So, you know, all the hospitals that are a community high public payer, half of them were above that last dot and half of them were below. And we do know even more detail at the individual hospital basis, which we could share after. For example, I think that the hospital with I showed a little bit on the slide that comes next of the hospitals that had the most negative margins. I think Haywood was, the biggest negative margin. So you'll be able to see that in the GEO report. It is an important aspect of all of this. Okay, back to you, David.
Any other questions or comments from commissioners? Right, then moving on.
David, given that last point, maybe I'd ask you to go back and teach us a little more. When we set a benchmark, my understanding is that we are not saying to every single hospital in the Commonwealth, this is your limit or your target, that there is difference among hospitals in their financial condition, and our staff know that. And the setting of the benchmark is, yes, it's a statewide goal, but it should not be interpreted as an exhortation to every single hospital to be at that benchmark. Is that fair enough?
Yes, Commissioner, that is fair. The statewide benchmark is, you know, a statewide target, a goal. It is not a cap on prices or spending on any individual provider or health plan. And in the process of determining an accountability to the benchmark through our performance improvement plan process and review process, we absolutely take into account many factors related to individual providers' performance, size, location, population served. So it is part of our role at the HPC to do that multifactorial review to really try to understand the differences, the important differences, and the important variation that exists within our healthcare system. I will speak a little bit more in a few slides just to kind of crystallize some of these points, but I'll make this point now and repeat it again later. The referral standard for entities to be referred to the HPC for a potential performance improvement plan is based on their growth in health status adjusted total medical expenses. And the metric of total medical expenses is developed based on attributed patients to primary care physicians. And so entities referred to the HPC for review are only in the provider side, physician organizations, managing physician organizations. Individual acute care hospitals are not referred to the HPC because they are not subject to a TME-like measure. This has been an important limitation in the CHIA referral process that we have recommended changes to. But just to be clear, individual hospitals are not subject to referral through that process. So moving on to the next slide, did want to provide here a summary of the testimony received. We had 10 organizations provide testimony on the 2024 benchmark. This grid just shows their positions relative to where they would like to see the number be set. And the recommendations were generally, well aligned within, but not necessarily across market sectors or different stakeholder sectors. So the employer representatives largely argued that small businesses are struggling to afford rising premiums and recommended that the HPC maintain the benchmark or to modify the benchmark back down to 3.1%. Consumer representatives who testified highlighted the ongoing affordability challenges facing patients and families, and advocated for consistency in setting the benchmark. Health plan representatives recommended keeping the benchmark at the statutory rate of 3.6%. They cited the return of pre-pandemic cost drivers in the most recent trends and argued that a more aggressive target is necessary to achieve the Commonwealth's goals. And finally, provider representatives generally questioned the relevance of the benchmark in the current market conditions and argued that there are many factors that contribute to spending outside of a provider's control, such as inflation and labor costs. These organizations generally did not advocate for a specific alternative number, but generally rather called for a revisiting of the state's cost containment framework. On the next few slides, we did want to take this opportunity before we turn to the decision at hand to once again just provide important context about the benchmark, how it is set, and how it is used. These are questions that often come up in the course of talking to many different stakeholders about the benchmark. These are questions that have come up in the course of the benchmark hearing and previously. And so as staff, we wanted to be able to kind of provide a clear and concise and in one place answer to some of these frequently asked questions. And I'm going to be presenting this with one of our directors of market oversight, Kara Vidal. So first, the question is, what is the healthcare cost growth benchmark and how does it relate to prices? As Commissioner Berwick teed up earlier, the benchmark is a statewide target for the growth of total healthcare expenditures. Total healthcare expenditures includes the sum of all healthcare expenditures, both Medicare, Medicaid, commercial insurance, as well as the net cost of private health insurance. The benchmark does not act as a cap on price growth or spending growth, but is actually designed as a measurable goal to track our state's progress and to motivate collective action. How has the Commonwealth performed against the benchmark over time? Over the last 9 years, our average annual growth in total healthcare expenditures has been 3.52%. That is lower than the potential gross state product target of 3.6%, but slightly higher than the average annual benchmark, but well in line with the targets that were initially set and quite consistent over time when averaged over time. Finally, want to talk about the relationship between the benchmark and inflation. The law defines a default or a statutory benchmark that is indexed to this concept of potential gross state product. Potential gross state product is an economic measure that was carefully considered and intentionally chosen in the drafting of this legislation. Potential gross state product is defined as the long-run average growth of the Commonwealth's economy, excluding fluctuations in the business cycle. And by design, PGSP does take inflation into account over time. This metric is designed by nature to be more stable and predictable. And that was seen as a feature in the drafting of the legislation to provide to the market a clear and sustainable target to moderate cost growth. On the next slide, I'm going to turn it over to Kara to run through a couple more of our FAQs.
Thanks, David. Good afternoon, commissioners. So the next question here is, how are individual providers and payers held accountable to the benchmark? And that is done as a shared responsibility between the Health Policy Commission and CHIA. So CHIA is responsible for collecting data on individual payer and provider performance and using that data to refer entities to the HPC for further review and a potential PIP. CHIA's referrals are determined using a standard algorithm that's based on health status adjusted total medical expense growth. And that algorithm is applied identically to all payer books of business and provider contracts that CHIA has data on. But it's important to note that referral to the HPC alone does not automatically trigger a performance improvement plan. Our job is then to take that list of referrals and provide a more comprehensive assessment and contextualization of each entity's spending growth. So we look at a wide range of metrics, as David was alluding to previously. We look, for example, at baseline spending levels, pricing levels. We look at size, market position, payer mix, population served, and more. We look at performance over time to identify patterns of concern. And we compare performance for the individual entity with market norms or statewide averages, market averages, to really try and identify areas where that spending growth is out of line with the market overall. Only after this robust review can the HPC require a PIP if it finds that an entity's costs are excessive and that the entity threatens the ability of the Commonwealth to meet the benchmark. Okay, the next question here is, are acute care hospitals, specialists, nursing homes, and other providers referred to the HPC for their spending performance? And David actually answered this one just a few slides ago very comprehensively. So I won't belabor the point here other than to just reiterate that CHIA's statute specifically defines the term health status adjusted total medical expense growth that it must use to refer entities. And because, as David explained, total medical expense exists for primary care groups, but does not exist for these other provider entities, they cannot be referred to us. The one other point I did want to note here, though, is that once an entity is referred to the HPC, we do try to look as broadly as possible at their spending drivers. So if we found, for example, that a provider group that was referred to us was affiliated with an expensive hospital, and that its own patients' use of that expensive hospital was a major driver of its spending trends, we can take that into account in our review, and in a potential PIP might expect them to consider the role of that expensive hospital in their trends. Can we go to the next slide, please? Thank you. The next question here is also about applicability of the process. So are pharmaceutical manufacturers and pharmacy benefit managers held accountable for their performance against the benchmark? So here, this is a clear no. Not only do these groups not have total medical expenses, as we previously were discussing, they also do not constitute providers or provider organizations. And CHIA's statute defining how it refers entities is specific to their ability to refer only payers, providers, and provider organizations. The next question here is, can the HPC set differential growth benchmarks for different types of entities? We often get this question in the context of not necessarily different provider types, but providers with different payer mix, for example, different pricing patterns, different spending patterns. And the short answer is that we cannot. The HPC can't set different targets for different sets of entities. State law requires a single benchmark for THCE growth. And so the decision before the board today is whether to set the benchmark at that default 3.6% rate or to modify it up or down. That being said, I do like getting this question because I think it speaks to a very important fact that we agree with, which is that a single metric like health status adjusted TME growth is not sufficient to understand an entity's performance. And that's why it gives the HPC that add-on role beyond the referrals from CHIA to contextualize, to assess, to better understand drivers. And as David said before, and I also said before, we really do try to look at a very broad range of measures to try and consider factors such as payer mix and pricing, baseline spending levels, financial position, factors outside of the control of the entity. All of those feed into our process. And then if we could flip forward one more, the last question from me before I hand it back over to Director Seltz is how our process has evolved to account for changing market dynamics. Obviously a question I think at the top of everyone's mind this year, last year, and rightfully so. I think that's a very appropriate and important question. We absolutely understand that there are spending drivers outside of the control of payers and providers, and we really do make an effort to take those factors into account in our review process. The COVID pandemic, the inflation and staffing shortages, these are obviously the biggest market disruption that we will have ever dealt with in the PIPS process, but it's not the first. Other examples that come to mind include the launch of high-cost hepatitis C drugs that had a very identifiable impact on pharmacy trends for payers and providers. We, in the year that those drugs were introduced and were really changing trends, we spoke with many payers and providers who were able to decompose those trends for us and show us what their trends would have been absent the introduction of those drugs. Also, a big market change that we looked at was the implementation of the Mass Health ACO program, which saw incredible movement of patients between payers and between providers as there were new affiliations and ACOs being developed, which made it really difficult for us to look at year-over-year trends because we weren't evaluating the same population in the first year as the second year. So I highlight these just to say that we will be taking the same approach in this year's PIPS review cycle to account for the impacts of the pandemic, inflation, staffing costs, rebounds in utilization, et cetera, including using annualized trends in addition to year-over-year rates, continuing to compare to market averages, and a very important step in our process, asking payers and providers where we do identify concerns or questions to tell us about the impacts directly on them. Our process always involves for higher concern entities an opportunity to speak with our staff, explain things to us that we can't see in the data, and allow for mutual learning between us and the entity on how our process works and how they see their trends. Turn it back over to David.
And finally, has HPC made recommendations to evolve our approach? The answer here is a resounding yes. HPC has made several legislative recommendations in our annual cost trends report, including updating that CHIO referral standard, incorporating accountability for the pharmaceutical sector, establishing affordability standards for health plans, and increasing investment in primary care and behavioral health care. These recommendations are further summarized on the next slide, and I won't go through them again, other than to say we really look forward to working with the Healy-Driscoll administration and the legislature to advance these statutory changes, which will provide the foundation for us to evolve our benchmark approach for the next 10 years. And so with that as all of the background on the benchmark and the hearing, I will turn it back over to Chair DeVoe.
Thank you so much. Thank you to all of the HPC staff for the background leading us into our discussion for the day, which is whether we want to vote to maintain the existing statutory rate for the healthcare cost growth benchmark, which is 3.6, or whether we want to move to modify that statutory rate either upwards or downwards. And I will open the discussion up to all of the commissioners, either with any additional questions or information that you want from the staff, or to express your views. I'll start us off by expressing my own position on the benchmark, which is that I've thought a great deal about both the feedback that we received at the hearing and about the reasons that we might want to vote to modify the existing benchmark. And where I'm landing is to confirm the benchmark as it stands. I'm not seeing the value of considering increasing the benchmark. I think given the challenges that we have around affordability, and also that we did not get any formal feedback at the hearing or in writing with any of our stakeholders recommending that we increase the benchmark. I think the flexibility that our staff has described, if an entity exceeds the benchmark in terms of our being able to consider factors, means that we don't have, in my view, a compelling reason to increase the benchmark. And similarly, in terms of balancing some very, critical consideration around wanting to strengthen the benchmark by reducing the benchmark given the affordability challenges that we know are so compelling in the Commonwealth. I'm finding it difficult to justify doing that at a time when we are hearing we're seeing different data points in 2022 about what's happening with the pressures on the delivery of care. I think 2023 will be an important year for us to understand how that stabilizes. So I'm looking forward to others' perspective on this. And let me open it up for comments and other commissioners' views. Commissioner Cutler?
Thank you. I want to weigh in sort of where you are, Madam Chairman, but I actually maybe I could be slightly more long-winded about it. Because David Auerbach looked like he was having so much fun, I actually have a couple of charts I'd like to show because he can't have all the fun around here. So David Seltz noted that the benchmark increase is supposed to be related to the growth of potential gross state product, which is exactly right. And that's got two parts to it. It has a real growth part, that is what is happening to output per worker or productivity per worker. And then the second is the price part, that is what is happening to the prices. And the biggest event that's of course happened in healthcare in the past 1.5 to 2 years has been a very big increase in prices, particularly of input prices of workers. And so so I thought maybe it would be helpful, although you can tell me, please don't, but I thought maybe it would be helpful to just sort of show a little bit about how I've been thinking about that and how I suppose in general economics has been thinking about that. Is that okay if I
Yes.
walk through that a little bit?
Thank you.
So I just want to show two charts. So first, can folks see this?
Yes.
Okay, so this is kind of what's happened to think about prices. So this is like the level of prices here, and I just start off at 100, and so prices are going, and now all of a sudden you have a big increase in prices, right? So the orange line here is what would happen if there were no increase in prices above normal. It would go on like this. Of course, what we saw in healthcare, as in the economy as a whole, was a very big increase in prices, right? So inflation rate was very high for, certainly for 2022 and also in 2021. And so anytime you have a price increase like that, wages go up, the sort of firms have to raise their output prices. And so that's what's happened across the economy. And we're seeing some of that, I think, in healthcare. The real issue is then what happens after that. And I think there are two sorts of things. One is it could, if you will, get built into the price level. That is, everybody's wages went up 7% instead of 2%, but then from that new level, they come back down to 2%, but they never reverse that 7%. They just stay at the 2%. So they're built into the level. And that's what this is here, built into the baseline. The other one is that they come down over time. So that initial price increase is actually reversed later on. That is, wages go up, but then wages come back down. That's, for example, the story that we saw with Sovaldi and other hepatitis C drugs, where the prices, a new drug came out, the price was really, really high, and then the price of those drugs fell, so that by a few years later, there was some increase, but a much smaller increase in the amount of spending for a population. And so sometimes that happens. So so in this kind of situation, either of these kinds of situations, firms need more money because their prices have, their costs have gone up, but not their prices. In this scenario here, the sort of one-time increase, you just kind of want to give them a one-time bump of money. Just say, look, here's some money. This will sort of take care of what this hump is. In the one where it's built into the baseline, you need to be sort of flexible for a year, sort of raise prices for a year, but then not expect you're going to take it out. Just in essence, build that into the baseline of prices. So we've obviously seen this part, and the question is, what will we see going forward in terms of price increases? The third scenario, which I didn't show you, is continuing large price increases. So if you look at as close as we have to sort of a professional forecast of prices, This is what you'd get. So this is the Congressional Budget Office. So, in 2020, inflation was 1.3%. It was then 4.5% and 7% in 2022. They show it that their forecast is that it moderates very extensively. And then by 2024, which is the year we're setting the benchmark for, it's down to 2.5%, basically on its way back to 2%. And so their forecast really looks like this one here. So it really looks like the one which is we had a jump up in prices, and we will not reverse it. That is, we will not go below the 2%, but it's going to, in their forecasts, taper off very rapidly. So if you take this as the most likely scenario, which there's no who the heck knows, but this is not a doctored forecast in any way. It's just it's the best guess of a bunch of folks who've looked at it. If you take this, you'd say that we will almost certainly miss the benchmark as we adjust to this by prices having gone up to providers in 2022 and 2023. And I think at least nationally, there's some evidence of that. And I think locally, there's some evidence of that too. But that after that, we should neither expect to have higher inflation, nor unfortunately to have lower inflation in terms of input costs. So that after that's built in, we should think about going back to where we were. Now, is where we were 3.6% or where we were 3.1%? I'm not sure. I could certainly see us going in either of those ways. It doesn't look like the where we were based on these forecasts should be 1%. That is far. It doesn't look like the where we were should be far below that. Nor does it look like the going forward from 24 will be that much higher, because the forecasts for inflation just are really tailing off fairly rapidly. So I think we sort of have to be lenient here as we get these numbers, and then somewhere in this range, depending on the same set of factors that we had thought to look for, which would be in the 3.1 to 3.6 range. So I don't know if that was helpful at all, but that's at least a graphic version of how I've been thinking about this.
Yeah. Very useful data and the different scenarios and understanding. Thank you. Commissioner Berwick?
Thank you, Madam Chair, and thank you, David. That was I always learned from you. That was really very helpful. I'll just start with my punchline. I strongly prefer 3.1%, and will have difficulty supporting 3.6, Madam Chair. That is not out of any disrespect for anybody who's thought this through. These are difficult matters. The staff is terrific, and many commissioners will disagree with me. But I've watched this happen now over my entire tenure, and the story never changes. There's always an excuse for prices that rise exceeding the rate of inflation for the average citizen. I continue to view the setting of the benchmark. Our duty is not to make a prediction, it's to make a prescription. And if you look at the testimony from the cost trends hearing, I'll say I was not able to be at the cost trends hearing, but I thoroughly reviewed all the materials available. We hear from small businesses, from the people that actually pay the bills. And if you look at David Auerbach's figures, more and more from individual citizens who are feeling more and more of a pinch. All sectors are feeling the pinch in this economy, and we need everybody on board to set things right. I don't think we should give a pass to the healthcare sector to continue to see rises above those experienced by general people in the economy. And I'm very, very worried about our citizens. I know that this is contentious. I know that some would accuse us of being tone deaf if we were to go in the direction I would recommend. But I think something's got to change the dynamics in this healthcare market. This state continues to be an outlier in cost compared to other states. And it's hurting us. It's hurting our ability to invest in the public and private sector. Something has to change the dynamics. So I would say this is our one chance. Well, it's not our one chance. It's our main chance as a commission to truly send a signal that this is not a game, There are people being hurt by these cost rises, and it's got to stop. Now, from the point of view of hospitals and providers that would be affected by this, I sympathize with them. I empathize with them. This is hard. David's comments on the supply chain costs and labor costs, I totally understand. But that's their job. Their job is to contribute to setting right healthcare costs in this Commonwealth that are not right. They're out of control. I have every confidence that if the signals are straight and the pressure is strong, that the healthcare system has can recruit the imagination and the intention to change, but it's not going to happen from inside. It has to come from outside, and that's who we are. So, with all due respect, I will express my my difficulty supporting the 3.6% target.
Thank you. Very, very important perspective. Commissioner Cohen?
Madam Chair, and Don, I appreciate those remarks, and I appreciate David's education on costs. And Don's remarks resonate with me as someone who has to go out and provide health insurance for their employees, and I've seen the costs that that we are now required to pay for a family plan. And as I mentioned at the cost trends hearing, now exceeding $40,000 for a family plan, and very few options to try to address that. That being said, I think we need to look for balance. There are tremendous headwinds that providers are still facing, be it inflation, be it workforce, and I think we have to balance that. I think 3.6 allows us to do that in a way, so I think we can't let those headwinds stand in the way of our desire to try to constrain the growth of costs. 3.6% still adds, if my math is right, about almost $2.5 billion to our healthcare spending. So there is opportunity there for growth. And I just want to also add, because of the questions that came up earlier about the differentials and looking at other factors, having participated in some of those performance improvement plan discussions with providers, even though that's a confidential process, I can say that there is really a lot of thought and analysis that goes into understanding for each provider what they are facing and what they're coming up against as they are referred to us, and to truly take that into consideration as we're thinking about performance improvement plans. So obviously we need to have a benchmark in order to continue to do that. I think 3% will get us there, and I would favor that.
Thank you. It's tough to disagree with Dawn, but the issue that I have is, as Martin had stated, the industry has issues. And I was surprised by looking at the margins on how high they were. And I was just wondering how much federal funding has impacted those margins. That's something else to look at. But the problem is, and my main concern is, if we make things tighter, how does that impact the quality of healthcare as well? And I think for the next year, I personally believe we're better off at the 3.6% rate. And when you're looking at inflation, although David, that was a great chart showing the inflation rate. And as David knows, that varies by state as well. And typically in Massachusetts, I'm sorry to say, typically has a higher inflation rate than most states in the country as well. And although organizations are looking at that 2% level in around a year or so, other organizations are looking at closer to 3%, which would also impact how we're doing as well. And that's why I think that at this year, I think that 3.6% makes the most sense.
Thank you. Undersecretary Sen.
Thanks so much, Chairperson. So I wanted to sort of build on some things that Commissioner Berwick surfaced earlier in some questions and the really helpful FAQ that David and Kara provided. And it focuses whether we are closer to 3, closer to 3.6, this notion that, by law, we need to decide on one number. The Health Policy Commission cannot sort of offer a differentiated set of prescriptions, if you will, that really reflects the diversity of our market. So when the Secretary convened us here in EHS for a huddle on this question, I wanted to share that really one theme that emerged is the benchmark is this single target for the entire state. And notwithstanding, the Health Policy Commission's best efforts, there are a lot of market participants out there, a lot of stakeholders, and it can end up being applied as a blanket number in a way that is not intended based on the conversations we've had today and we've had in other forums. This is despite the fact that the reality of our state is, with an existing distribution of healthcare resources and health inequities across communities, that really requires a more nuanced approach. So first and foremost, want to take Edie Seltz up on his invitation to continue partnering with our fellow commissioners and HPC staff to keep an eye out that, particularly as we seek to strike that right balance and to send that strong prescriptive message, to borrow Commissioner Berwick's term, that the benchmark is not inadvertently being applied to entrench those existing resource disparities across our communities. And that ideally this time next year, we could be voting on a more nuanced set of tools in our toolkit.
Thank you. Commissioner Castillo.
So I'm looking at a community that can't afford the insurance. I'm looking at a community who can't get the medications that they need because they can't afford it. I'm looking at a community who feels that they won't go in to see the physician because they can't pay for their copays. I think the cost of insurance overall for small businesses is skyrocketing. They can't afford it. And I agree with Don that we need to send a message that we can't continue to grow in this manner. And yet when we grow in this manner and we're increasing the cost, we still don't see the outcomes that we're supposed to be seeing. We still continue to have inequities in healthcare. We still have a poor life expectancy, and that hasn't changed. And so we need to figure out how to do this better. Thank you.
Thank you. Commissioner Foley.
Thank you, Madam Chair, and really hard to look at this little thing, and you guys are on the screen, but we're supposed to look here, so I'm gonna try my best to focus on the owl, I guess it's called here. But I really do appreciate the conversation. The data is always to help inform some of our decision making, and I thought the presentation for me, that what I'm taking away is what the benchmark is and what the benchmark isn't. And I think that's really important for our discussion. As laid out in the question and answer, I was trying to hit a buzzer to answer some of the questions during that section of the agenda, is that it's a measurable goal to track progress, that we have to set a standard of what we're trying to accomplish as a state and as a healthcare industry to reach this measurable goal that we can hold each other accountable to. And I think that's the other piece, is that the goal of the benchmark is not the whole, is to hold folks accountable that are having the biggest impact on costs in the state. And that we heard from the commission staff and from our executive director, how those factors are taken into consideration when folks are referred to CHIA I say it a lot in these meetings that not all spending is equal in this market. And I think we take those things into consideration while thinking about a PIP process or to move forward with one, or the impact and the benchmark by individual providers or payers. And there's limitations to who we are able to bring into that process. And I think we've seen in the presentation and have been clear for a number of years now, there are significant policy recommendations that the HPC has put forward that we think are really important to get at the cost drivers, to bring more folks into the PIP process so that we can look at the industry holistically of who's having the biggest impact on driving up costs, which the previous commissioner spoke to, which is real impacts for low income families and people of color throughout the Commonwealth. And so I think 3.6 in this environment does make sense. But I think that for me, it's in the bigger picture of what the benchmark is, what it's not, how we utilize the CHIA data to enforce folks that are having the biggest impact on the cost drivers in Massachusetts, and with the need, a desperate need, to increase the tools that we have as a commission to really target that work, bring more of the stakeholders into this process so that we can hold the drivers of costs accountable to their above benchmark spending. And I think all those things go into my thought process. 3.6 makes sense given the environment in which we are in currently, that it's a goal that we're measuring, that we have to hold all of the industry stakeholders accountable to, that we don't currently have the tools to do, and that we need action based upon those recommendations to increase the tools that on our ability to hold ourselves and the healthcare industries, everyone accountable to that benchmark. And so 3.6 within that framework, I think it's the right way to go. But I do believe deeply that the impact of these cost drivers is affecting low and moderate income folks more than anyone else. And we cannot forget that in our deliberations and in improving the benchmark, how we utilize it and who's drawn into the process. So thanks for the opportunity.
Thank you. Any other thoughts, comments, or questions? Am I missing anybody?
Don raises his hand.
Commissioner Berwick?
Thanks. As always, a wise set of comments. I think that one of the takeaways for me is we need a clear signal, not just to the providers of care and the plans, but to the legislature. The legislature has not acted on what I think is maybe the most important document we've ever produced, and that's the list of recommendations that is now 3 years old. I wouldn't be in this pickle about having to decide about 3.1 or 3.6. If we could be more discriminating by statute, I would have a different benchmark for the large academic medical centers and the small stressed community hospitals. I'd have a different benchmark for pharma. Problem is, don't have that option. And so, I mean, I deeply respect the commissioners, and I'm clearly in a minority, but someone's got to draw some line here, and say, or I think we're going to end up in the same conversations year on year. I think it's a time to make a statement about what the people of the Commonwealth need. Madam Chair, one other point I forgot to make. One of the reasons I prefer 3.1, although I'm in the minority, is precisely that our staff have so much discretion. With a very stringent benchmark, we give them more tools to have serious conversations with various providers about their particular condition, which is a conversation I would love to encourage. I think that that's a very important part of the commission's portfolio, that our staff actually can have the kind of deep conversations that Kara was talking about.
Very good point. Very good point. Other thoughts? Questions, comments? Commissioner? Well, I'm very glad that our discussion reflects exactly the range in thinking that we received from stakeholders. You know, I realize that each commissioner has gone through their own thought process, but I think means that we're representing the understanding that we were also hearing from the different stakeholders that came to the hearing and in writing, which is that there did not seem to be a compelling reason to consider raising the benchmark. Despite the pressures around the provider community that had been discussed here and at the hearing, since our goal, as Commissioner Berwick stated, is not to try to project cost, but to offer an aspirational goal and a prescription. There did not seem to be any discussion today or in the feedback around increasing the benchmark. I think really our focus has been around whether to confirm the statutory rate or whether to create a lower benchmark. And also hearing the discussion today and in the presentation by staff, a strong commitment by the commission to pursue with the Healy Driscoll administration some changes to the benchmark process that we know would enable us to do a better job. With that, let me pause and ask whether we're ready to move to a motion for a vote. Or any other comments or thoughts before we move to that?
And while we wait, I'd ask for the motion to be put up back on the screen, please.
So from what I'm hearing from the discussion, let me propose that we start by proposing a motion to establish the healthcare cost benchmark at the statutory rate for 2024, which is 3.6.
Is there a second to the chair's motion?
Second.
Okay, thank you. I will start with a roll call vote. Again, this is an up or down on 3.6%, starting with you, Madam Chair.
Aye.
Vice Chair Cohen,
Aye.
Commissioner Berwick,
No.
Commissioner Blakeney, are you here? Didn't see you. Okay. Commissioner Castiel,
No.
Commissioner Cutler,
Yes.
Commissioner Foley,
Yes.
Commissioner Haupt,
Yes.
Commissioner Master Giovanni.
Yes.
Commissioner Kwasnick,
Yes.
and Acting Undersecretary Sung.
Yes.
Thank you. Thank you.
Thank you. Very, very much appreciate the discussion and the emphasis on the importance of the consumer in this and the fact that there's an important view that the benchmark as it stands send a message around the balance and not to underestimate the concerns and impact around affordability for consumers. So thank you, commissioners. We'll now move to the discussion of the final regulation for the Office of Patient Protection. And I'm going to turn to Nancy Ryan to lead us in that discussion.
Thank you very much. Good afternoon. As Chair DeVoe said, I'll be presenting on the Office of Patient Protection's final regulation and asking for a vote from the board today. Just as a reminder, this slide lists OPPs for primary services offered to consumers. And the presentation today will focus on the second bullet, health insurance appeals. And on the next slide, you can see this is an overview of the areas that impact OPP from Chapter 177 of the Acts of 2022, also known as the ABC Mental Health Act. It amended OPP's duties in several areas. And the sections relating to health plans, internal grievance process, as well as OPP's external review process necessitated regulatory changes. The next slide goes over the timeline for the regulatory promulgation and the activities that the HPC has undertaken to implement the law. As you'll see, OPP issued interim guidance in October in advance of the law taking effect in November 2022. As you know, the board issued the proposed regulation in January for the public comment period, followed by a hearing in March. The next slide, I'll go into a little bit more detail about the public notice and comment period. It ran from January 25th through March 9th. The proposed regulation and notice of public hearing was posted on the HPC's website on January 25th. We also went through all of the other noticing requirements required by the Secretary of State. We held a public hearing on March 2nd. We had actually no participants provide testimony at that public hearing, so it was a pretty quiet hearing. We did have 2 written comments received by March 9th, which was the deadline for receiving public comments. We received comments from the Massachusetts Association of Health Plans, or MAP, as well as Point 32 Health. Each organization requested only a couple of minor changes to the proposed regulation. The comments were really focused on technical issues related to health plan requirements. And the next slide, I'll discuss the few comments we did receive in more detail. So that first row, MAP requested that the regulation track the language of the statute so that the plans may deliver and accept medical release forms through either a designated email address or through an online portal, rather than both, which was required under the proposed regulation. We're going to recommend making this change in the final regulation to be consistent with the statute, which does allow the plans to deliver those forms either through email or through an online portal. In that second row, you'll see a summary of MAP and Point 32 Health's request that OPP change existing noticing requirements such that plans would not have to mail a written notice within 72 hours of receipt of an expedited internal grievance. Just some background, this 72-hour requirement of a mailed notice was unaffected by amendments in the proposed regulation and has existed as a requirement for plans since 2014. Therefore, OPP does not recommend making any changes to this existing regulatory requirement in the final regulation. The last row, you'll see Point 32 Health requested clarification on the timeline for sending notice of an insured's right to a conference. This conference was previously only available for those with a terminal illness, but the statute broadened this right to any insured who lost their expedited internal grievance. In response to this comment, we do recommend making changes to the proposed regulation to clarify the deadline for plans to send this particular notice. In order to avoid 2 different consumer notices and provide clarity for both consumers and plans, we recommend aligning the timeline to send notice of the right to request a conference with the timeline for resolving expedited internal grievances. So in the final regulation, 1 notice must be sent by plans within 72 hours that includes all the required information, including the right to request a conference, if applicable for that insured. We believe this change reduces administrative burden for the plans and also allows for more streamlined communication to insureds about their rights after an expedited internal grievance. So at this point, I will pause for any questions that commissioners have before asking for a vote.
Any questions? Comments? Very clear. Excellent job, Nancy. Thank you. So sounds like we're ready to turn to a vote. You're not seeing any hands up that I'm not. Okay. Great. Let us turn to the vote if you can take us through that.
Great. Do I have a motion to establish this new regulation?
So moved.
Thank you. And a second?
Second.
Thank you. Okay, Chair DeVoe.
Aye.
Vice Chair Cohen.
Aye.
Commissioner Berwick.
Aye.
Commissioner Castiel.
Aye.
Commissioner Cutler.
Aye.
Commissioner Foley.
Aye.
Commissioner Haupt.
Aye.
Commissioner Master Giovanni,
Aye.
Commissioner Quaznik.
Aye.
And acting Undersecretary Sung.
Aye.
Thank you.
Great, thanks so much.
And that concludes your vote
Very
for
much.
today, Madam Chair.
Okay, thank you. So we'll now move to our next agenda item, which is to share findings from what will be a soon published evaluation for our innovations program. And I'd like to introduce Kelly Hall, our Senior Director of Healthcare Transformation and Innovation, to start us off.
Thank you very much, Chair DeVoe, and good afternoon, Commissioners. I would like to introduce two members of the Healthcare Transformation and Innovation team. Taylor Bungo, who's an Associate Director and the Operational Leader of the Shift Care Challenge, and Catherine McLean, a Manager on our Evaluation team and the author of the upcoming report on the Shift Care program. If your memory is good and you feel like you've already heard about the evaluation of the Shift Care program, you are not wrong. Last fall, we shared the results of another track of Shift Care that focused specifically on initiation of medication-assisted treatment for opioid use disorder in the emergency department. The track we're addressing today speaks very specifically to investments aimed at two key drivers of health outcomes and cost: health-related social needs and timely access to behavioral health services. So Taylor and Catherine have a lot of interesting information to convey to you today, and I don't want to duplicate them. So with that, let me turn it over to Taylor.
Great. Thank you, Kelly, and good afternoon, Commissioners. I'm excited to be back with you today to share the other half of our Shift Care story. So as Kelly mentioned, and as you may recall, in January of 2018, the HPC issued a request for proposals for the Shift Care Challenge. This was an opportunity to implement some innovative care models to address whole person needs. And Shift Care had two tracks. One track was dedicated to addressing behavioral health needs, with 9 of those awardees focused on opioid use disorder. And the other track was dedicated to addressing health-related social needs. Today, I'll be discussing 6 awardees, 5 of whom focused on health-related social needs, and 1 whose focus was timely access to behavioral health, but it was outside of the OUD space. Next slide, please. So after a very competitive review process, the board approved 6 awards in this cohort. And as you can see here, the recipients reflect the geographic diversity of Massachusetts. And you also notice that there are actually more sites on the map than there are awardees. And that's because half of the awardees had multiple sites of care across Massachusetts. Next slide. As mentioned previously, the Shift Care Challenge was focused on funding innovative models to address health-related social needs and behavioral health needs, with the goal of decreasing the use of avoidable acute care. Awardees were granted up to $750,000 with 3 months of preparation and 21 months of program implementation, followed by an evaluation period. And despite the heterogeneity and the types of needs that each program addressed, there were common areas of focus across the board, including partnerships with community-based organizations and also an effort to improve patient experience. Next slide, please. Here you'll see a list of the 6 awardees in the HRSN BH cohort, as well as their award amounts. And as you may recall, Shift Care stands for Sustainable Healthcare Innovations, Fostering Transformative Care. So we wanted to structure this program to reinforce our emphasis on sustainability. And to that end, we required each awardee to have a 25% in-kind investment from their own organizations. You can see those listed awardee contributions on the slide. And then next to it, you'll see the remaining 75% of the total investment that came from the HPC. Next slide, please. On this slide, you'll see the 6 awardees from the cohort listed, along with a brief summary of their care models. And as I mentioned before, there was a lot of variability in the type of care model for each program, including the particular need that each awardee was addressing. So for example, the Bay State Healthcare Alliance team designed a program to address asthma in families, while the Boston Medical Center team, for example, provided innovative training to their pharmacists to screen and address a variety of health-related social needs. Other awardees focused on housing, complex care management, integrated treatment for mental health, and care coordination for medical, behavioral, and health-related needs. Next slide, please. Finally, I think it's important to be reminded of the context in which these awardees were operating towards the end of their programs. So as we all know, in March of 2020, when the public health emergency was declared, awardees had anywhere between 3 and 8 months left in their implementation periods. In response, the HPC temporarily paused engagement with awardees to allow time to respond to the public health emergency. And then after some time, we reached out to reassess the status of the programs. So you'll see a table at the bottom of the slide that summarizes the operational changes that occurred as a result of the pandemic. During this time, we used the colors green and red to facilitate a quick visual snapshot of the types of impact on these programs. Red represents areas where the pandemic had a negative impact on the awardees' ability to implement the full scope of their programs, while green represents either an absence of negative impact or, as it relates to the last column, a positive change that actually enhanced programs overall. You'll notice across all 6 awardees, the pandemic impacted a number of categories, including partner engagement, scope of work, and their ability to collect data. Some staff had to take on COVID-related duties in addition to their program work. Others had slower enrollment or had to extend the number and types of services that patients needed. And across the board, awardees experienced confounding impacts on utilization due to the pandemic. The final column on the right represents the adoption of telehealth or telecommunication. As shown by the yeses in this column, all awardees adopted some form of telecommunication in order to stay connected to patients while face-to-face contact was limited. The yeses shown here are in green because this change was really an enhancement to these programs as opposed to an obstacle to delivering care. So now I'll have the honor of passing it over to my colleague, Catherine McLean, who will discuss the evaluation portion of this presentation. Catherine?
Thank you very much, Taylor. Good afternoon, everyone. Next slide, please. So once our awardees had navigated the challenges of the pandemic and reached the end of their implementation period, we then proceeded to the evaluation. And this slide lays out the structure of that process. The HPC set specific requirements for the awardees to conduct evaluations of their program, including requirements around data collection, including acute care utilization measures, intermediate measures, which were awardee selected and included improvements in social needs status, process measures around the program, or health status measures related to the program. A measure of patient experience was also required, and this typically took the form of awardee-administered surveys to participants. The requirements that the evaluation be led by the awardees was laid out in the RFP for the program. A number of evaluation-related deliverables with specifications developed by the HPC were required over the course of the program, culminating in a final evaluation report that awardees submitted at the end of the evaluation period. The awardees could choose to conduct this evaluation with an internal team or subcontract the work to an external evaluator. Some did a mix of both. Our team at the HPC reviewed and approved deliverables and other data collected during the program to identify key findings and themes from the implementation. These were developed into the final evaluation report, which will be released shortly and from which this presentation is drawn. The report is divided into 2 sections. The first looks at themes from across the cohort, and the second presents individual findings from each awardee. Next slide, please. Here we present a broad overview of the findings. As Taylor mentioned, there was great heterogeneity among the programs, both in their care models and their intended and actual outcomes. So characterizing them broadly can be somewhat challenging, but we had some overall takeaways here we wanted to share. First, most awardees did see some downward trends in acute care utilization in at least one area. Typically ED visits and revisits, inpatient admissions and readmissions, or composite measures of these types of utilizations were what was tracked. The compounding impacts of drastic reductions in utilization during the pandemic often confounded analyses, and in some programs, small sample sizes also limited analysis. However, the downward trends that were observed were a positive indicator, and as we'll see in further awardee-specific results, some clear decreases were noted. Awardees reported on a number of intermediate measures demonstrating positive impacts of the programs, and clear improvements were seen in several programs, which we'll discuss in more detail on the next slide. Finally, the programs also reported strong performance on patient experience. This was a required component for all programs, and the majority of programs scored extremely highly on at least one measure of satisfaction with all participants who were surveyed. Next slide, please. Diving a bit further into specific highlights of awardee data, you can see here that among the awardees that had strong results in acute care utilization were Hebrew Senior Life, top left in orange, who saw a 22% reduction in readmission rates, while comparison senior living sites not implementing their program saw an increase over the same period. At Boston Medical Center, the bottom right in gray, there was a reduction in the number of program participants with instances of acute care utilization, either ED visits or inpatient admissions, during the follow-up period of their program. Given that they enrolled from a high utilizing population, this was a positive indicator. In terms of intermediate measures that showed significant positive results, the Bay State program demonstrated enormous improvements in measures of asthma control, with 82% of children with uncontrolled asthma at the beginning of the program showing controlled asthma by the final visit. The tool that was used to measure this, the asthma control test, has been extensively studied, and other literature indicates that at least a 3-point improvement, which these participants did exceed, is clinically significant, and cost savings can be anticipated at a population level with increased levels of asthma control. At Community Care Cooperative, or C3, the top right in navy, there was a 54% increase in food security among participants who graduated from their program. And Holyoke Health Center, at the bottom left, which was our behavioral health focused awardee, they reported more than half of participants had a kept psychiatric medication appointment within 90 days of enrolling in the program. Finally, illustrating the high level of satisfaction participants had with the program, 84% of those in Steward Healthcare Network's Care to Community program were satisfied or very satisfied with the amount of care they received. Finally, we do just want to highlight the over 1,200 participants across the Commonwealth who were served by these programs. Next slide, please. As I mentioned, in addition to synthesis of these quantitative findings, we also work to analyze the collected qualitative data for broad themes present in the programs that we've highlighted here. First, the role of non-clinical staff was absolutely critical to these programs. Many of them employed community health workers and found them essential to providing the increased time and attention that was necessary for the success of participants in these programs. And they were extremely well suited to the role of connecting participants to services to address their health-related social needs and behavioral health needs. Programs also tailored their responses to health-related social needs based on their population, their program design, and what was feasible for them. Different communities had different needs and resources available. For example, while many awardees addressed food as a need, Hebrew Senior Life program focused on specific nutritional needs for their older population, in addition to general food insecurity. Another theme that arose was the impact and implications of the fact that all of these programs were being implemented within a larger context, which included larger systemic forces such as poverty and housing shortages that our awardees had to contend with as they tried to meet participant needs. This often created inequities which impacted the health of participants. Awardees made many attempts to be responsive to these realities in their programs through their interventions, such as through training about health inequities for staff, but also had to be reasonable about the level of progress they could make with certain needs in the time allotted. This highlights both the importance of resources to support these additional needs and opportunities for programs that intervene on these systemic factors, such as the Health Policy Commission's current Mass Up investment program. Next slide, please. These themes continue here with the critical importance of partnerships to these programs. The HPC required community partnership in these programs, and the partners the awardees worked with added key expertise to their programs and extended and expanded their capacity. One example was from C3 was their medical legal partner, who were not only able to help with typical legal concerns in their youth population, but provided information to families on their special education rights during the transition to remote learning at the beginning of the pandemic. And then, of course, as has been already stated, we cannot tell the story of this program without acknowledging its intersection with the pandemic. Our awardees demonstrated great fortitude and flexibility in the midst of enormous upheaval and found opportunities to continue supports in things like telehealth appointments and distant supply drop-off, but also had to contend with new and changing needs in participants and the deep impacts the pandemic had on healthcare, data collection, and their ability to deliver these programs. Many participants lost touch with the programs, and new needs arose that were sometimes outside of the program's original scope. The perseverance and dedication of our program staff was extremely admirable, and we've also had to acknowledge the significant impacts of the pandemic as we have conducted our evaluation. Next slide, please. Finally, we want to highlight aspects of sustainability in these programs. Again, noting the time frame that these programs were wrapping up in 2020, it's remarkable in some cases that any portion could be sustained in such a challenging time for healthcare. First, we have two examples of sustaining program elements. Baystate was able to transition the asthma supplies portion of their program into the flexible services portion of their Mass Health ACO. Hebrew Senior Life had been successful in an earlier iteration of their program, which was also funded in part by the HPC, in securing some funding from payers in a per member per month form to support the program. And they continued engaging payers during the SHIFT program with the aim of achieving full financial sustainability for the program without grant or internal funding. In several cases, it was the partnerships that sustained. Here we illustrate another example from Baystate, in which their housing remediation partner, Revitalize CDC, remains involved in supporting patients through their flexible service program. And Revitalize CDC has also hired their own CHWs to provide asthma education to non-ACO clients. Steward Healthcare Network planned to continue partnerships with their medical legal partner and also organizations that provided peer recovery coaches for those in their program that needed them. Finally, recalling the theme of the importance of community health workers in these programs, some awardees incorporated these staff roles that were used in their shift care programs into other parts of their organization after the program ended, such as a community care cooperative and Holyoke Health Center, who both added CHWs to their existing care management departments because how much value they saw from these roles in the shift programs. Next slide, please. So that concludes our presentation on findings from the soon-to-be-released Shift Care report. Before we move into questions, we wanted to highlight some of the outputs from our team based on the work in this program. We've already released several briefs on key types of partnerships in these programs, including medical legal partners and EMS and mobile health partners. We also released a spotlight highlighting the work of Hebrew Senior Life to adapt their program in the midst of the pandemic. We'll soon be releasing, of course, the full evaluation report and an impact brief highlighting findings from the program, and also another spotlight highlighting the exceptional work the Baystate team did in creatively adapting their program, addressing some additional initial obstacles during implementation and improving the health of those with asthma. Thank you for your time and attention. Happy to take any questions now.
Great, yeah, terrific to see the results of the program and also encouraged by the elements that are sustainable, both in terms of quality and cost. Thank you. Questions or comments? Commissioner Castillo?
I just wanted to know if when you were talking about the outcomes or satisfaction, was race and ethnicity taken into account?
So the data that was provided to us by the awardees regarding their patient experience was not in this program stratified by race and ethnicity. That wasn't a requirement we had by them. That is something we're hoping to do in future patient experience work and other investment programs, because we are aware that there can be significant impacts there that we want to have an understanding of.
I agree with you. I don't think we should be doing a whole lot without looking at race and ethnicity in everything we do.
Thank you.
Commissioner Singh?
Great presentation. Happy to take more of these questions offline. But in terms of understanding some of the learnings from this work and how they might be scaled, I think it's great to see some of the insights line up with sort of exactly where we need to go in terms of integration, social determinants, behavioral health, and measurable outcomes. So would love to learn more about sort of the thinking where next from here. Understand there is certainly, there must be a portfolio sort of activities that just with the new administration here in EHS, it would be great to learn more about. Thanks.
Yeah, absolutely.
Yeah, we would welcome the opportunity to share the learnings from this or any of our other programs focused in these areas.
Commissioner Foley?
Yeah, thank you. I just wanted to dig in a little bit on the workforce piece. Clearly, I think one of the things I learned from this and other programs is just how these innovative programs really integrate the direct care staff into the care teams. And so I'm wondering how did we see that through some of these grants? Were they new staff that were brought in specifically for these grants, or was it staff that was already existent that got moved into the programs? And then the last question around the workforce is, was there a focus on language capacity, particularly with the community health workers? I just want a better understanding of how the workforce pieces came into play, both engagement, newer transition staff, and language capacity. Was that a key priority or skill for the direct care workers?
Yes, absolutely. So in general, it was a little bit of a mix. I would say probably the majority of the staff, and particularly the direct care staff, were new hires funded with their roles specifically funded by the shift care dollars. But they were often integrating into teams with supervisors or other clinicians who had been at the organization prior. And we did see efforts by a number of organizations to focus their hiring around the language needs of their particular participant populations. And that was also a key area of team collaboration, where if one CHW maybe was assigned to a specific region, but happened to get a client who spoke a language that they didn't, but another one of their team members did, there was a lot of sort of bringing each other in and working together to ensure that those needs were met. And there's a great deal more detail about the staffing structure of the programs and workforce, as well as some of those language efforts in the full report.
Great, thank you. Is the funding complete now? Is there any funding left for the programs, or is this the end of that shift care program?
Yeah, the funding has concluded for that program.
Thank you. Other questions or comments? Okay, great. Thank you so much. So we'll now move to our next agenda item, which is around the healthcare workforce event. We produced a report recently. The HPC produced a report on the data regarding the healthcare workforce trends, and we held an in-person event at Suffolk on March 29th. So our focus today is to have an opportunity to debrief from that meeting, both in terms of summarizing the presentation for those of you who were not able to attend, and also what we learned from the discussion and where we go from here. So with that, I'll turn it over to David Seltz to take us through the presentation.
Great. Thank you, Madam Chair. So 2 weeks ago, the HPC hosted this special event, as you said, at Suffolk University, and it was, I thought, a tremendously successful event with a lot of incredible, thoughtful testimony and perspectives shared from a diverse group of stakeholders and healthcare workers. We hosted this event very intentionally because we and you, the board, had identified the opportunity, and not only the opportunity, but the imperative for the HPC to use our convener role to bring together stakeholders to discuss this really important topic that has implications for healthcare affordability, healthcare equity, and healthcare access. At the first meeting of this year, we walked through some of our policy priorities for the year, and addressing the healthcare workforce and identifying solutions was one of the top priorities that the HPC board had recommended that we pursue. Additionally, the legislature has also identified this as a very important topic and had mandated that the HPC develop some additional reporting using our independent and objective analysis to provide greater insights into the trends in healthcare workforce. This interest was tremendous in terms of the event. The interest to participate in person exceeded the capacity that we had at Suffolk University of 160 people. And additionally, we had over 200 people viewing on the live stream. So close to 400 people across the Commonwealth were viewing or participating in the event. We also had a number of commissioners who were there in person. I look forward to hearing your thoughts and perspectives on the event. And I do want to thank the two commissioners who moderated our stakeholder panels. Finally, we also had a number of key legislators and legislative staff that attended the event as well, again, reinforcing the interest and importance of this topic. On the next slide, you can see just an overview of the report and the chart pack that we released in conjunction with the event. The HPC's report included an overview of broad workforce trends, as well as the current workforce challenges and potential solutions for different occupational groups within the healthcare workforce. For this report, the HPC focused on registered nurses, direct care workers, and behavioral healthcare providers, which comprise about 65% of the Commonwealth's healthcare workforce, each of whom have experienced unique difficulties. The HPC understands that there are other healthcare workforces that have also experienced challenges, and we look forward to continuing this research into other areas. Rather than presenting a number of slides from the report, we wanted to show you a short video that we've prepared, we call an HPC short. An HPC short is a 2 to 3 minute YouTube video that summarizes some of the key data from our report. And in this case, I think is a nice summary of some of the key themes from the report. So why don't we watch the video?
While the COVID-19 pandemic is moving out of its most acute phase, its effects continue to challenge the healthcare system and healthcare workforce of Massachusetts. Healthcare workers provide care in many settings and make sure that patients get the care they need at each stage. Even before 2020, healthcare workers reported challenges such as high turnover and a lack of support. The strain of the pandemic has exacerbated these challenges and disrupted patient care. Limited staffing can mean that patients are unable to get care when they need it or may spend too long in the wrong setting of care. To understand the crisis facing the Massachusetts healthcare workforce, the HPC examined workers in nursing, direct care, and behavioral health occupations, and explored challenges at each stage of the workforce life cycle to understand how employers and the Commonwealth might begin to address them. Challenges for registered nurses in Massachusetts are concentrated around employment and retention, because difficult working conditions often contribute to turnover. The strain of providing care during the pandemic and the reliance on contract nurses for staffing have led to increasingly unstable work environments, leading some nurses to leave their current jobs or to retire from the workforce altogether, exacerbating challenges for remaining nurses, who may then leave themselves. By contrast, challenges for direct care workers span all stages of the workforce life cycle and are mostly related to wages. Training can be expensive, and workers receive low wages for high responsibility work, often with limited opportunities for advancement, which can lead to turnover and attrition. While Massachusetts has more nursing assistants and aides per capita than the U.S. as a whole, employment in these roles has fallen rapidly. Direct care workers may leave patient care for less stressful jobs with fast rising wages outside of healthcare, especially because the cost of living is high in Massachusetts, and housing, food, and other expenses often exceed what direct care workers earn. For behavioral health care workers, challenges are related to the high cost of training and the division of care provided in person and via telehealth. The HPC found the fastest employment growth in settings where care can be provided via telehealth, compared to slow or falling employment growth in more intensive or inpatient settings. Wages are a common reason for recruitment and retention challenges in behavioral healthcare work as well. Solutions to the current workforce crisis will be different for different kinds of workers and will require sustained investment from both employers and the Commonwealth. For nurses, employers should focus on retention, for example, with mentoring, increased administrative support, and schedule flexibility. For both direct care and behavioral health care workers, employers should focus on opportunities for professional development and advancement, and the Commonwealth should reduce barriers to entry with upfront funding for training, including for behavioral health roles that need advanced degrees. Full findings and recommendations are published on the HPC's website.
Well, thank you to the team that prepared that video and to Charlotte for narrating it and being a key research analyst on the report. We presented these findings at the event, and to follow the presentation on the chart pack, we had two really excellent panels. The first panel is shown on the slide here right now, and these panelists represented those three sectors that we really focused on in the report: registered nurses, behavioral health care workers, and direct care workers. And there was a good discussion amongst this panel around their current efforts and challenges, their efforts to increase the diversity of their workforce, and policies that they would recommend that the Commonwealth pursue in order to be able to support a greater and more stable workforce. On the next slide, we then followed with a second panel that expanded the conversation to some key leaders across the Commonwealth, and really tried to shape this conversation about solutions and common collaborative action that public and private actors can take together to identify, to moonshot solutions to address these challenges. Finally, on this next slide, we put together our own takeaways in terms of some reoccurring themes and potential solutions. But I will pause on this slide and would love to open the conversation up to board members who were in attendance at the event to share their own reflections and thoughts about what you found most interesting or impactful, and as well as open it up to questions from commissioners who were unable to attend.
Any thoughts or comments from commissioners?
I'll start.
Please.
I mean, I thought it was a really great event to bring together the stakeholders that we did to have the conversation about the impact of COVID and issues that were prior to COVID. I really was hoping to keep driving the conversation around solutions. I think it's similar to what we just talked about with the benchmark, where we have a lot of policy solutions we need to enhance the tools to control costs, and doing the workforce report, coming up with solutions to address one of the biggest issues we're experiencing in healthcare right now, which is the workforce issues. So I thought it was really important that the HPC convene that conversation. I think we've got to keep driving towards solutions. And if we could think about the next phase of healthcare around HPC and our role around the cost trends benchmark spending, as well as around the workforce issues, I think bodes well for trying to address some of the key issues facing delivery of care right now in the Commonwealth, which is the costs and the impact on workers. I think the report was very well done. I think we've seen now a lot of people utilizing it both in the press and in public comments and hearings. I used it just the other day in a hearing about the need to improve wages for CNAs and nursing homes and home care workers. So I think it's really highlighted and gave some real important facts and figures for folks to continue to raise the issues that need to be addressed if we're going to be able to maintain the care delivery system that we have in the Commonwealth and ensure that the workforce is taken care of. Talk a lot about particularly low-wage workers in the CNA and the home care space are taking care of their poor people, taking care of poor people. And how do we ensure that we lift those wages so they can continue to be in care and also improve the working conditions. I think that's the other big takeaway that I had, particularly around RNs and others, but the real need to engage the workforce. I think we heard about in the prior presentation with some of the grant work that's been going on around engaging the workforce, thinking about their roles differently, incorporating them into the team, because if we're going to recruit and retain talented caregivers, they want to be part of the care delivery team and they want their voices heard in decision-making around how that care is delivered. And they have a lot of insights into that. So I think it was really important. I think it was a great conversation and I look forward to the next phase of that, which is action to be taken to address these concerns. Because if we don't, our healthcare system is going to be in a really difficult position for a long time to come.
Thank you. Commissioner Castillo?
So I thought it was a great event. I am, you know, if I take each one, I think we talked about the nurses and that nurses, you know, came on the field to see patients and they're loaded with paperwork and the inability to really spend the time that they want to spend with their patients. And how do we support them? What do we do to support them through that process? We looked at behavioral health, and certainly we know we have a shortage of behavioral health clinicians. And in particular, we also have a shortage of behavioral health clinicians of color. How do we increase that pipeline? How do we increase looking at those healthcare, those people who are working in healthcare, and how do we move them up the ranks, and how do we train them to become, whether it's CNAs, whatever that piece is, to assist the nurses and everybody else in the healthcare and to get some stuff off their plate. We also talked about, I'm trying to think, I lost my train of thought, but I think overall, I think we were all on the same page about what are some of the things that we're seeing in workforce and what we need to do. I guess I didn't come out with what are we going to do differently. I do like the pilot programs that were mentioned before. They were it shows that we could come to some movement on the things that we do. I think the other piece that I just remembered was talking about community health workers, recovery coach, that ancillary help that is needed. And again, we don't pay people well, and people tend to go elsewhere. And that's the same thing with behavioral health. But I guess my piece is how does this get implemented? And that's where in a larger form, how does this get implemented, I guess is my question overall. But I thought it was a great forum, and it was good for me. I learned a lot and appreciated all the comments there. So thank you.
Thank you.
And good point. We'll turn to what happens next in a moment after we finish this discussion. Other thoughts or comments?
Commissioner Cutler.
Commissioner Cutler? Commissioner Cutler, yeah.
Sorry, yeah, no, I was just figuring out how to unmute myself. I too thought it was terrific, and I thought that the report and the presentation were great. And I do want to come back to what happens next, which is, I know I'll just defer that for the moment. But one thing that struck me about it is that I think in some ways what we're observing now is both a short-term impact of COVID and a longer-term response to the Commonwealth not having invested itself appropriately in regenerating a workforce and making healthcare be a place where people want to work. So you know, it sort of showed up in COVID, but there were many predictions that it was going to happen for many years that we, as everywhere else in the country, has ignored. And I think that we're going to have to deal with it both in the short term and over time. And I really want to make sure that as we think about next steps, they include both immediate things and also things that will come to fruition, not necessarily immediately, but help us down the road.
Commissioner Cohen?
Thanks, Barb. Thanks. It was a pleasure to attend. First want to thank Commissioner Foley and Commissioner Castile for their great job in moderating the panels, which, as well as the data, I think the data was really compelling that was shared by David and his team. Just 2 points sort of picking up on what David Cutler just said. One, the workforce issues in behavioral health have been here pre-COVID. And we've known that, and the conditions that we see, the backup in emergency rooms, the emergency room boarding has been with us pre-COVID. Yet, as I pointed out at the meeting, we have the highest per capita rate of mental health professionals of any other state. So I think it sort of speaks to David's point about really focusing in on these issues in a concerted effort. But it also, for me, raises the question of whether we need to think about different models. I mean, telehealth obviously is one, but are there the use of peer supports, recovery coaches? We just heard about the importance of community health workers. Really thinking about differently about what's being provided and by who. And then lastly, as a recommendation of where we go, I think we need to have a discussion with higher ed here. I think there are some opportunities, particularly around pipeline and particularly with engaging maybe even high school students to be interested in careers in healthcare. They were not part of the discussion, but I hope they are part of the discussion within other areas of state government, because they're essential if we're going to deal with this problem. I had a discussion with a community college president about, associate's degrees in behavioral health. And his response to me is, it'll take us about 18 months to 2 years to get that through the Board of Higher Ed. We don't have 18 months and 2 years. We need to act quicker. So they really need to be part of the discussion.
Commissioner Blakeney has her hand up.
Please, Commissioner Blakeney.
Thank you very much. And I very much appreciate the conversation that I've heard so far. I think the pieces that I took from that program was, number one, especially with the second panel, the degree of consistency in talking about innovation and the need, and I believe Marty used the word a moment ago, of testing new models of care. Taking a look at new models to provide services and where can we provide those services in places that are the least expensive to provide the highest quality care. We've already demonstrated that to some extent from going for inpatient to ambulatory to outpatient independent centers. But what else can we be thinking about doing? What combination of clinicians do we need to put together to provide optimal care? And that doesn't necessarily look like what we're currently doing or what we did pre-COVID. So I'm encouraged by the willingness to acknowledge that innovation and testing new models is an essential part of trying to find solutions to this. I don't think there's one solution. I think there are solutions in many different places. And I think in order for it to all come together and be impactful, it all needs to happen concurrently. And Marty's point about associate degree programs and not having 18 months to 2 years, how can we engage the educational structure, the approval structure in the state to move quicker? And what does that look like? How can we build bridges from associate degree programs to baccalaureate programs and beyond? How do we fast track that opportunity without, underline without, sacrificing the standards of education and practice to get there? So those are all things that I hope we can bring to the table, and I hope that we can use to solve the challenges of very high cost care and very high cost insurance premiums that are driving people away from care. You can have the best institution in the world, but if people can't afford to get there, it doesn't matter. It doesn't matter. So how do we rethink that? What do we need to have on the table for what kinds of patients when? And how do we ensure that we do that and that primarily? So I think we have a lot of things to talk about going forward. And I think we do it best when we do it in partnership with other stakeholders, so that we have those conversations and we listen first and don't leave any group or any organization behind in these discussions. So thank you, and congratulations to the staff for putting together not just one program, but two programs in very short order with incredibly helpful information and data. Very much appreciated and very much a part of framing my thinking going forward. So thank you to the staff for that.
Here,
Thank you.
Thank you.
Any other commissioners who are asking? Okay, great. Yeah, I'll just add before we turn to conversation about what next. I'll just add that I was very glad to receive a lot of positive feedback about our role in this as an independent, producing the independent report and also as a convener. So I think the commission had identified this as an area we knew was of tremendous importance to the Commonwealth and one that we want to be part of the solution and having an impact. And this is one of those moments where I really see the value of our independent role in being a source of facts and ability to convene. So was very glad to hear that. So with that, shall we turn to discussion of what next?
Yes, absolutely. And first of all, thank you, commissioners, for all your kind words. And I will defer all of those kind words to the staff that made the event such a success and the staff that produced a really incredible and important piece of work. We are enthusiastic about continuing this work with all of you. As we put together this next slide shown for you here with some kind of, I think, more kind of practical next steps. But even as I'm reviewing this and reflecting on the conversation that we're having today, I think we may need to even broaden our thinking about next steps to kind of maybe categorize some as kind of like, what are we doing in the next 6 months versus things that are going to have longer term impacts? What are small things that we want to focus on versus the bigger picture of how we pay for and deliver healthcare, and all of these things are interconnected. And I take the comments with a spirit of really wanting to spend more time digging in on this, and so I think worth carving out time in future board meetings and in future events, as Commissioner Blakeney said, to bring others to the table to continue these conversations. I've laid out here just for discussion and for reaction. I fully admit now that these are not the big moonshot, bold ideas that are going to break the cycle, but certainly want to keep this momentum going. And so we do see opportunities to partner with our sister agency, CHIA, who is working on doing more regular workforce surveys to allow us to get more real-time information about the challenges and trends, and to understand more about the diversity of our healthcare workforce. As mentioned, we did focus on 3 particular kind of professional sectors in this first report. We do see that there is an opportunity to examine other sectors within the healthcare settings, either different types of settings or different types of professions. Certainly we've heard a lot, and a lot has been reported about the challenges in primary care and wait times to receive a primary care visit. Community health centers are unique settings of care that face their own challenges. And so worth us spending some time to use our research and independent expertise to continue to provide objective data, information, and facts on a range of different professions and settings. Obviously, an opportunity to collaborate with other state agencies, both labor and workforce development, higher education, and of course, the Executive Office of Health and Human Services. And I want to acknowledge Undersecretary Karen Sung, who provided the keynote opening remarks for this event on behalf of Secretary Walsh. And those remarks, I think, highlighted the administration's commitment to working on these issues and the particular commitment to the relationship between healthcare workforce and health equity. We've talked a lot about administrative burden and waste, and this is an interrelated factor when it comes to our healthcare workforce, the pressures that they're feeling, how that contributes to burnout. And so any continued efforts we have on relieving some of those administrative burdens, I do think is related to some of our workforce challenges. And as I said, an opportunity to, identify different issues and hold, smaller events, bigger events, but having that opportunity to engage in dialogue. I will put this out for discussion, but I think worthy of continued conversation about how we shape our portfolio in this particular topic.
Just a process question. So the report's been produced, and I'm assuming it has to be sent to the legislature. Like, who does the report go to?
It went to the legislature. Yes.
Okay. Okay.
Yeah.
We're just thinking about these potential solutions as being highlighted in some of the work that we're doing to really drive the solutions piece of this. And just thinking about maybe the role of the advisory committee too, to look into some of these potential solutions, to put some real ideas on paper about what could be next in terms of broad potential solutions into clear approaches to solving some of these issues, and utilizing the board and the advisory board to get feedback on some thoughts could be an immediate next step.
I think that's a great idea. I mentioned this at the event, but we brought our kind of policy priorities for action to the advisory council at our first meeting this year. And I think we got to the second bullet, which was workforce. And then that was the rest of the conversation for the meeting. There was tremendous interest and tremendous support from the advisory council. And that is a truly, as you'll hear, an incredible group of professionals who bring a lot of expertise into this. I think, setting aside the next advisory council meeting just to kind of reflect on this, identify some, commitments for action would be, a tremendous, kind of initial next step. And they are eager to be partners and to be supportive of our work in this area. Thanks.
Other thoughts about next steps, Commissioner Brewer?
Yes, thank you. As I put in the chat, there's a lot of federal activity going on here, and also that's through the Office of the Surgeon General. And also there's a National Academy of Medicine, very large action collaborative on workforce well-being. I'm on the steering committee of that collaborative and have been associated with it for a number of years. It's developed a playbook of activities. I don't know if the HPC has connected to the National Academy of Medicine on this, but it could be very valuable resource in two directions. One is that HPC and the further work here could benefit from the thinking that's gone on in the National Academy and the current resources. And second, I don't know of any other states that are part of that action collaborative, and I wonder if it'd be worth exploring active participation. There's people working on this all over the country.
Yeah, thank you, Commissioner. That's a great idea. And if we haven't, we certainly will, and I'll reach out to you to maybe help make a connection. I would note that we did invite some of our staff from some of our federal elected officials to attend the event. Many of them attended in person and online, as well as some of the other federal agencies like HRSA that is investing a lot in here. And so the importance of coordination and collaboration across all of these different government sectors, I think, is really important, because there is funding being put into these places, but how is that funding being targeted? Is it being coordinated to scale real impact? And perhaps we can have a role in just trying to understand the landscape a little bit better.
Commissioner Cutler?
I think Barbara was there before me. I'm happy to wait.
Sure. Commissioner Blake?
David, that's fine. I always listen very attentively to what you have to say, so please go ahead.
Okay. So I want to agree with all the comments that have been raised. I also want to, I genuinely have a question I'm sorry, let me just go back 1 second. One of the things that we did hear about, just related to Don's Berwick's point, is the burnout from staff, particularly in hospitals, is very real. Feeling like they're overstretched and threatened by patients and don't have time and so on. And so it's part of the problem is people are moving from hospitals out to other settings because the satisfaction with work is just much higher there. And so I do think thinking about ways to try and address the work environment would be very valuable. But I also want to come back to, like, are there specific recommendations we can make to the legislature? And I think following some of this up in terms of what is our capacity to increase the supply of workers in Massachusetts, either through training models or through licensing of workers who have been licensed in other states, or in terms of upskilling workers. It might be helpful to, outside of our annual report, to have a set of workforce oriented recommendations that we could give fairly soon to the legislature that would help them, because this is something where I think some action has to be taken more rapidly than is typical.
Good.
Thank you, Commissioner. Yeah, I think if we can provide, recommendations to the legislature, I think they are open to our thoughts and our recommendations. This is certainly a very topic that is top of mind for many, and I think there's a lot of momentum around trying to identify those solutions. And so I think we can absolutely play a constructive role in that, and let's continue talking about what those would look like.
Commissioner Blakeney.
Yeah, and I apologize.
Please don't. I know I'm not on screen, and my apologies for that. I also apologize for the picture that's up of me. It was a great picture to take, and it was a fun day, but it's not the picture I necessarily want to have up on Health Policy Commission. Two things. One, putting on my innovation hat, the idea of having one super idea that just knocks everything out of the ballpark is a disruptive innovation. And those happen relatively infrequently, but all sorts of improvement innovation happens all along the way. And I think that while our aspirational issue is to find that disruptive innovation that fixes a lot with one, I'm going to mix my metaphors, one silver bullet, we should try for. But I think that the ability to find multiple areas in which we can make improvement adds up. It might be 10% improvement here, it might be 20% improvement there. Together it adds up. And so I think that reaching in critical areas that we identify as, number one, needing that kind of modeling and innovation, and two, have a oversized impact on the cost of what that might be and the efficiency of what that might be is a good approach. But a disruptive innovation is it's hard to come by. We should try for it, but I think in the meantime, and in addition to that, we look to make the improvements and encourage the improvements that we see along the way based on the data that we're looking at and based on the feedback that we're getting. We need to engage providers in that conversation. Providers on the ground know what needs fixing in their world. They're not shy about telling you what those things are. We need to be able to engage with them and to hear what they're saying. When I was at Mass General as the innovation specialist, I worked on individual units. And together, because I was working with the clinicians, we made substantial changes that had an incredible impact on what happened on those units. And we made differences in metrics that were important. Thank you. That's it.
Thank you. Other thoughts and comments? I want to really underscore what Commissioner Castile was saying earlier about the administrative burden. I really left the session with renewed energy. My energy level was already high, but renewed energy after hearing many of the presenters referencing how the workforce was being affected, both in terms of not having enough time to necessarily comply with all the administrative burden and also not seeing the value. So it becomes a concern around burnout. So that's another important theme that's in our next steps and on our continued radar screen, but just want to underscore that.
If I could, I just also want to identify another opportunity for partnership, which is with the Health Equity Compact. The Health Equity Compact has made, the diversification of our workforce a priority. We had many of the Health Equity Compact members on our panels at this discussion who were tremendous and just brought so much insight into how important these efforts are. And I think they would be great partners to think about how we can collaborate together on some of these solutions. So I want to put that out as an opportunity as well.
Great. Other comments? So based on the discussion, let us go back and flesh out the next steps more fully, reflecting the input from today, and we'll come back at a future meeting and talk about where things stand. Good, thanks so much. So now we'll turn to our last formal agenda item, which is, as you know, at every board meeting, our executive director gives us a report on highlights of the moment, and I'll turn it over to both David and Colleen Elstemeyer to give that report.
Great, thank you, Madam Chair, and we've reached our last agenda item of the day, which is very exciting. So very pleased to report today that earlier this year, we appointed a reconstituted advisory council to better reflect our goals and priorities for the 2023 to 2024 term. In February, we convened the advisory council for the first time. This slide shows the full slate with the new members in highlight. We did appoint 10 new members, business community reps from provider orgs, mental health advocates, frontline workers, DEI experts. These incredible new members, along of course with our returning members, bring diverse perspectives and experiences to our council, very much help and inform our work. We work with all of these people and organizations behind the scenes, so there's really much more collaboration that happens outside of the four corners of the 4 official meetings of the year. So thank you to our advisory council members for volunteering your time and your expertise and for your partnership as we work together this year and next year. Noting that our board members are welcome to attend our advisory council meetings. Many of them do, very welcome, and all are broadcast on our YouTube channel like the meeting today. So congratulations and thank you all for your service. Really appreciate it. On the next slide, I have my usual upcoming and recent publications. As usual, a lot of material recently released here from the HPC. Just a few highlights on the left-hand slide. The HPC shorts that you just saw on healthcare workforce. That's on our homepage, that's on our YouTube channel. If you want to watch it again or share it, that would be great. The full chart pack of findings that we released at the event, also available on our homepage. And just I would also highlight a recent chart pack, incredible work from our research team, emergency ground ambulance utilization in Massachusetts. If you haven't had a chance to read through it or missed the coverage of that, I encourage you all to check that out. And then on the right side of the slide, on the horizon, the evaluation report coming out of the Shift Care program. You just heard findings from earlier today from the team. That's coming out very soon. We've got profiles. We do a profile of every single awardee that we fund in the HPC, no matter what program they're in. So we've got HPC certified ACOs. We've got the Beside investment program. Those are all coming out very soon. Then our next issue of our highly popular series Data Points is coming out on very timely issue, persistent cost sharing for contraception. So that's coming out very soon. So watch this space for that. And then finally, we've got a chart pack on opioid related acute hospital utilization. This is a data refresh on work that we've been doing over the years, over the 10 years of the HPC. So that'll be coming out soon as well. So, lots to look forward to. And that's before our cost trends report in September. Very exciting. On the next slide, this is a bit of a new series here. We wanted to take the opportunity during the executive director's report to highlight showcase one single health equity work stream that's working successfully within the agency. This will be an ongoing series in addition to our usual summertime agency-wide update on accountability and progress agency-wide on all health equity work. So here in the first slide here, I'm talking about our ACO certification program today. So we're taking steps in this program to ensure advancing health equity is a key expectation and core competency for all HBC certified ACOs. So through this program, it's a certification program, yes, but we can use the standards to achieve two different ends. One, gather information to better understand our ACOs' efforts and strategies to integrate health equity into their work, and two, to really set expectations and requirements for ACOs in this area. So we'll be identifying emerging areas of opportunity for ACOs to make an impact. We reviewed health equity submissions from the last round of ACO certification. We supplemented this with a broader landscape review of health equity requirements and targeted discussions with key stakeholders. And this process really allowed us to hone in on priority areas for the ACOs for advancing health equity, which then became the basis for the next round of requirements. So on the next slide, we've updated these standards this year to include tracking of progress that they're making in building their capacity to advance health equity. So in particular, focusing on three key areas of opportunity here. So articulating and advancing an ACO-wide vision for advancing health equity, using sociodemographic data to identify inequities and develop interventions to address them, and then finally engaging with patients who are experiencing health inequities in the design of interventions to address those inequities. So patient engagement element there for sure. And then finally on the next slide, this is just one example of how we're doing this work, how we're asking ACOs to track their progress in one of three opportunity areas. So in this case, the activity focuses on engaging the patients in the ACO's equity related work. So basically what happens is ACOs indicate their current status on the activity, select from a menu of options representing a continuum of possible progress, and then they go ahead and provide additional information and concrete examples to describe in more detail what the recent progress has been in this area, and then share plans for continuing to sustain and make progress over the next 2 years. So over time, our plan is to set the minimum status for expectations and then gradually raise the bar over time to encourage ACOs to frankly continue building this core competency. So that's the update on one health equity spotlight within our ACO program. Very happy to share that on behalf of our incredible ACO team at the HPC. And that's it for me today, David Seltz. I'll turn it over to you for some very important budget and administrative updates.
Well, thank you, Colleen. I have just a few administrative updates for the board today. This first administrative update is in relation to one of our investment programs, the BESIDE investment program. The BESIDE stands for Birth Equity and Support through the Inclusion of Doula Expertise, and it aims to address maternal health outcomes or address inequities in maternal health outcomes through the deployment and use of doula services. Last year, the board approved 2 awards to Bay State Medical Center and to Boston Medical Center to develop and implement these programs. The awards were for around $200,000 apiece. So fast forward to today, with about a year left in the implementation period for these programs, Bay State Medical Center has already surpassed its enrollment projections in terms of patients opting into this program. So they were in a position, they reached out to us to begin to start denying patients that were otherwise interested in being a part of the doula program, and wondered if there was an opportunity to expand the authorized funding. So I worked with the fiscal team here at the HPC, and we identified $50,000 of otherwise unallocated funding within our annual budget, and approved that additional funding for Bay State so that they can continue to enroll patients in this program. This change does not require a board vote. It is really just a contract change with Bay State, but I wanted to provide this update to the board so you all were aware of this change. My next slide is a little bit of an update on that state budget process. Again, each year we begin with the governor's proposal for the annual state budget. And we're pleased to report that Governor Healy and her team did support the budget appropriation that we have requested, which is a maintenance budget request of around $11.4 million. So now we move to the legislature, and we look forward to working with House Ways and Means and with Senate Ways and Means to see their proposals. I have been told that the House budget is now live and public.
That's correct.
And I believe we have some good news, but I will double check on that. And then on the right-hand side, you can see just a picture. As part of this annual process, we're asked to testify before the Joint Committee on Ways and Means. And I was so pleased to be able to have that honor to do that, and have to say the engagement and interest in the work of the HPC was tremendous. So we will be back with further updates on the budgetary process. We're planning a committee meeting of the Administration and Finance Committee, I think for July, to discuss our budget. And then our budget will come before the full board for approval, probably at the July board meeting. And then I believe finally, we have our standard slides just on material change notices that we do at every single meeting. This slide just shows our tracking of notices. We're at 148 provider transactions since our inception. Maybe we'll have a little party when we get to 150. But a brief update here. Since our last board meeting, the HPC is not elected to move forward to CMIR on 2 provider transactions. We are currently in a stage where we do not have an active MCN under review. And I would say that those moments in time have been fleetingly rare in the last 10 years. But we did close out 2 transactions since the last board meeting. First is the proposed purchase of LHC Group, which is a national provider of post-acute services with several home health locations in Massachusetts by United Healthcare Group. United Healthcare Group is a diversified national company that does include Atrius and Reliant in Massachusetts. Under the transaction, LHC Group will become a subsidiary of United. In our preliminary investigation, we found limited potential for increased spending in Massachusetts as a result of this transaction. While LHC and United are large national providers, they both have very relatively small presences here in Massachusetts. And Optum Health has a very small presence in the home health market in Massachusetts. A large portion of these services will be provided to Medicare patients, meaning that the market concentration concerns are not as impactful. And we did not see any evidence that the transaction would lead to negatively impact quality or access to care. Just 2 additional notes on this particular transaction. Oregon, in the last few years, has passed laws that are very similar to the HPC in terms of being able to track material change notices and do reviews of those transactions and make a judgment call about whether a full review would be warranted. They did a review of this exact same transaction in Oregon, and similar to us, did not find significant potential impacts on consolidation costs and prices, and they closed their review. Additionally, the FTC did have a review open on this transaction, and that review closed earlier this year. The second transaction that we closed was a clinical affiliation between Tufts Medical Center and Commonwealth Radiology Associates, or CRA. CRA is a large radiology program, physician group practicing in multiple locations in northeastern Massachusetts. Under the proposed clinical affiliation, CRA would become the exclusive provider of professional radiology services at Tufts Medical Center. Here too, we found limited potential for increased spending. We did not review evidence that the rates for professional radiology services provided at Tufts Medical Center would change as a result of the transaction. And any potential shift in scans is likely to be small and unlikely to significantly impact spending. We also did not see any evidence of negative quality or access impacts, and so closed review. Those are my 2 market updates. Happy to take any questions or comments on those. Seeing none, before I turn it back over to Chair DeVoe to close out our meeting, I just want to express my gratitude for the conversation today amongst all the commissioners. Incredibly thoughtful, and I look forward to working together in the next year on all of these important challenges, solutions, and to meet this moment. And so I thank you and look forward to the road ahead. So with that, I'll turn it back over to Chair DeVoe.
Thank you so much, David. Any other thoughts or comments about any of the items on today's agenda before we move to close? Any? Great. Well, thank you all so much. I mean, for me, this annual consideration of the cost growth benchmark is one of the most important things that we do. And I appreciate the robust and clear discussion about the balance in this decision and the fact that there's always going to be this concern around how this benchmark is going to affect the consumer. But want to thank everyone for that set of deliberations and vote. And before we close, just wanted to review upcoming meetings for those that are on YouTube and for commissioners. Our next full board meeting will be on Wednesday, June 7th. Looking forward to the two HPC committee meetings, which will be both held on Wednesday, May 24th. First, market oversight and transparency, and then care delivery transformation. These are all on our website with a full calendar and description, and we'll be finalizing the details around the in-person and Zoom hybrid. We are approved now to hold meetings for the next 2 years to offer the option of Zoom. So we're glad that that will happen because it's meant that we can have much fuller attendance and broader participation. So with that, I want to thank everyone. Happy spring.